The Cushing syndrome is a term used to describe the clinical state of increased free circulating glucocorticosteroid. It occurs most often following the therapeutic administration of synthetic steroids or ACTH. Normally, the hypothalamus, which is located at the base of the brain, secretes corticotropin-releasing hormone known as CRH, which stimulates the pituitary gland to secrete adrenocorticotropic hormone known as ACTH. ACTH then travels to the pair of adrenal glands on top of each kidney, where it specifically targets cells in the adrenal cortex. The adrenal cortex is the outer part of the adrenal gland and is subdivided into three layers: the zona glomerulosa, the zona fasciculata, and the zona reticularis. Zona fasciculata is the middle zone and also the widest zone, and it takes up the majority of the volume of the whole adrenal gland. The ACTH specifically stimulates cells in this zone to secrete cortisol, which belongs to a class of steroids or lipid-soluble hormones called glucocorticosteroids. Glucocorticosteroids are not soluble in water, so most cortisol in the blood is bound to a special carrier protein called cortisol-binding globulin, and only about 5% is unbound or free. In fact, only this small fraction of free cortisol is biologically active, and its levels are carefully controlled. Excess free cortisol is filtered in kidneys and dumped into the urine. Free cortisol in the blood is involved in a number of things, and it's a part of the circadian rhythm. Cortisol levels peak in the morning, then the body knows we need to get up and go, and then drop in the evening, then we are preparing for sleep. In times of stress, the body needs to have plenty of energy substances around, so cortisol increases gluconeogenesis, which is the synthesis of new glucose molecules, proteolysis, which is the breakdown of protein, and lipolysis, which is the breakdown of fat. Cortisol also helps to maintain the blood pressure by increasing the sensitivity of peripheral blood vessels to catechisins epinephrine and non-epinephrine, and this narrows the blood vessel lumen. Cortisol helps to dampen the inflammatory and immune response by reducing the production and releasing of inflammatory mediators like prostaglandins and interleukins, as well as inhibiting the proliferation of T lymphocytes. For all this to work properly, through the levels of free cortisol have to stay within the normal range. To do that, the body uses negative feedback, which means that high levels of cortisol tell the hypothalamus and pituitary gland to decrease their secretion of CRH and ACTH respectively. Less CRH also tells the pituitary to make less ACTH, so the pituitary ends up having two reasons not to make ACTH. With less ACTH floating around, the zona fasciculata gets less stimulation to make cortisol, and eventually, cortisol levels go back down to the normal range again. Cushing syndrome doesn't happen often on its own. It affects less than 5 out of every million people each year. Causes of Cushing syndrome are usually subdivided into two groups. First of all, it's too much ACTH hormone in the body in 65% of cases. This can happen in two ways. The pituitary gland in the brain makes too much ACTH. This is called Cushing's disease. Second is a tumor somewhere else in the body, not the pituitary, makes too much ACTH. This is called ectopic ACTH production. In both cases, the extra ACTH causes the body to make too much of the hormones cortisol. Second problem is an excess of cortisol produced by the adrenal glands in 25 of cases, which is not caused by high ACTH levels. This is called non-ACTH dependent Cushing's. In those cases, the adrenal glands make too much cortisol on their own, usually to a tumor or overgrowth of adrenal tissue. As a result, the body naturally reduces ACTH production. In rare cases, this happens because adrenal cells respond to hormones they normally shouldn't, such as glucose-dependent insulinotropic peptide, luteinizing hormone, or catecholamines, hormones like adrenaline. In Cushing syndrome, persistently elevated cortisol levels lead to exaggerated effects on the body. High cortisol causes significant breakdown of muscle, bone, and skin, the body's main protein reserves, resulting in muscle wasting, skin thinning, and osteoporosis. Cortisol also raises blood glucose levels, triggering increased insulin production. This insulin preferentially acts on fat cells in the abdomen and buttocks, causing central obesity as those cells accumulate more fat. Cortisol also leads to hypertension through two mechanisms. First, it enchains the effect of catecholamines on blood vessels, leading to increased vascular resistance. Second is cortisol can mimic mineralocorticoids by binding to their receptors, which normally responds to hormones that regulate blood pressure. This binding leads to fluid retention and further elevates blood pressure. Excess cortisol also disrupts reproductive function by inhibiting gonadotropin-releasing hormone from the hypothalamus, affecting ovarian and testicular function. Additionally, it suppresses the immune response, increasing susceptibility to infections, and can impair brain function, though the exact mechanism is unclear. Cushing syndrome can be caused by external sources of cortisol, such as prolonged use of steroids medications, or by internal overproduction of cortisol. The majority of cases are due to long-term use of exogenous steroids, which mimic cortisol effects and suppress the body's own cortisol production, potentially leading to atrophy of the adrenal cortex. Endogenous Cushing syndrome is often caused by excess ACTH, typically due to a pituitary adenoma, a benign tumor that secretes too much ACTH. This overstimulates the adrenal glands, leading to excessive cortisol production. Other causes include ectopic ACTH production from tumors like small cell lung cancer or adrenal tumors that produce cortisol independently of ACTH. Symptoms of Cushing syndrome reflect the widespread effects of excess cortisol. Patients may present with muscle wasting, thin skin, easy bruising, and abdominal stria, purple or red. Fat redistribution results in a characteristic moon face, a buffalo hump on the upper back, and truncal obesity. Other symptoms include hyperglycemia, hypertension, increased risk of cardiovascular disease, increased susceptibility to infections, poor wound healing, amenorrhea, and psychiatric disturbances. In diagnosis, there are two phases to investigation. First is confirmation. Most obese, hirsute, hypersensitive patients do not have Cushing syndrome, and some cases of genuine Cushing's have relatively subtle clinical signs. Confirmation rests on demonstration inappropriate cortisol secretion, not suppressed by exogenous glucocorticosteroids. Difficulties occurs with obesity and depression, where cortisol dynamics are often abnormal. Random cortisol measurements are of no value. Occasional patients are seen with so-called cyclical Cushing's, where the abnormalities come and go. Investigations to confirm the diagnosis include 48-hour low-dose dexamethasone test. Normal individual suppresses plasma cortisol to less than 50 nanomole per liter. People with Cushing syndrome fail to show complete suppression of plasma cortisol levels. Also, levels may fall substantially in a few cases. This test is highly sensitive, more than 97%. The overnight dexamethasone test is slightly simpler but has a higher false positive rate. Second is 24-hour urinary free cortisol measurements. This is simple but less reliable. Repeatedly normal values renders the diagnosis most unlikely, but some people with Cushing syndrome have normal values on some collections, approximately 10%. Circadian rhythms. After 48 hours in hospital, cortisol samples are taken at 9 hours and 24 hours without waiting the patient. Normal subjects show a pronounced circadian variation. Those with Cushing syndrome have high midnight cortisol levels, more than 100 nanomoles per liter. Through the 9 a.m. hours value may be normal. Midnight salivary cortisol collected at home gives the same information more simply where the assay is available. Differential diagnosis can be extremely difficult, since all cases can result in clinically identical Cushing syndrome. Biochemical and radiological procedures for diagnosis include plasma potassium levels. Hypokalemia is common with ectopic ACTH secretion, and all diuretics must be stopped. High-dose dexamethasone test. Failure of significant plasma cortisol suppression suggests an ectopic source of ACTH or an adrenal tumor. CRH test. An exaggerated ACTH and cortisol response to exogenous CRH suggests pituitary-dependent Cushing disease, as ectopic sources rarely respond. Chest X-ray to look for a carcinoma of the bronchus or a bronchial carcinoid. Carcinoid lesion may be very small. If ectopic ACTH is suspected, whole lung, mediastinal and abdominal CT scanning should be performed. Further investigation may involve selective catheterization of the inferior petrosal sinus to measure ACTH for pituitary lesions, or blood samples taken throughout the body in a search for ectopic sources. The successful treatment for Cushing syndrome typically results in the reversal of its clinical symptoms. However, if left untreated, the syndrome carries a poor prognosis with potential complications including hypertension, myocardial infarction, infection, and heart failure. Prior to surgery or radiotherapy, it is crucial to control cortisol hypersecretion to avoid significant morbidity and mortality, especially in patients undergoing abdominal surgery. Metarapone, an 11-beta hydrolyase inhibitor, is commonly used to reduce cortisol levels, with doses ranging from 750 mg to 4 g daily, divided into 3 to 4 doses. Ketoconazole at 200 mg 3 times daily is often combined with metarapone for a synergetic effect. Monitoring plasma cortisol is essential to maintaining levels between 150 to 300 nanomole per liter, which approximates normal production. The choice of further treatment depends on the underlying cause of Cushing syndrome. The choice for Cushing disease with pituitary-dependent hyperadrenalisms include, first of all, transphenoidal removal of the tumor is preferred treatment. Successful surgery leads to remission in 75 to 80% of cases, though outcomes vary based on the surgeon's experience. Postoperative ACTH deficiency is often a positive prognosis sign. Second is external pituitary irradiation, is an alternative for cases where surgery fails. Though it works slowly and is effective in about 50 to 60% of patients, children respond better with an 80% cure rate. Third is medical therapy to reduce ACTH levels. Medications such as bromocriptine, cabergoline, or somatostatin analogs like pathophysiology is usually ineffective. However, aggressive corticotropic adenomas may respond to temozolomide chemotherapy. And the last one is bilateral adrenalectomy. It is considered a last resort if other treatments fail, and this procedure can be performed laparoscopically. For Cushing syndrome due to other cases, for example adrenal adenomas, should be surgically resected once clinical remission is achieved with metarapone or ketoconazole. Contralateral adrenal suppression might persist for over a year post-surgery. Second is adrenal carcinomas. Adrenal carcinomas are aggressive with a poor prognosis. If there are no widespread metastases, surgical reduction of tumor bulk is recommended. The adrenoliptic drug meteotan may slow tumor growth and prolong survival through it has side effects like nausea and ataxia. Postoperative radiotherapy to the tumor bed may also be considered. Ectopic ACTH secreting tumors should be surgically removed if feasible. Chemotherapy or radiotherapy may be necessary depending on the tumor type. Controlling Cushing syndrome symptoms with miterapon or ketoconazole is important, and bilateral adrenalectomy might be considered if the tumor's prognosis is reasonable. And the last one is unclear sources of ACTH. Require cortisol hypersecretion control with medical therapy until a definable diagnosis is made. Nelson syndrome is increased pigmentation. A potential complication after bilateral adrenalectomy involves increased ACTH levels and pituitary tumor growth. The syndrome is rare now that adrenalectomy is an uncommon primary treatment, and its incidence may be reduced by pituitary radiotherapy soon after adrenalectomy. The Nelson's adenoma may be treated by pituitary surgery and/or radiotherapy.